Bueno, vamos a comenzar esta sesión.
Well, we'll start this session. Good morning, everyone,
A todas y bienvenidos a la
and welcome to today's session.
Mi nombre es Roberto Tapia,
My name is Roberto Tapia. I'm a consultant of systems of health services of PAHO WHO in Brazil.
escenario
And
virtual.
as a moderator in this virtual scenario, I will be joining you as a host for this upcoming 2 hours. Let me tell you, this is the fifth and last webinar on the series of politics options to strengthen the framework of the health systems of America in PAHO.
Versiones ya están familiarizados con la dinámica.
Maybe you've been in previous sessions, so you're familiarized with our theme and our topics. We wanted to thank you for joining the session with people from over 40 countries, and today's not the exception. Today we have an important amount of participants from across the region, and we would like to increase this number probably in the next few minutes. I have to mention that this webinar is also a part of the celebration of the International Health Day under the motto, making the world that we want and the future that we want. This is a part of a series of activities that have been developed in behalf of universal health, so we can understand and share the situation of people, families, and communities that still lack of access and coverage of essential services, quality and essential based in the primary health service, and to enlighten and shed some light in the values that we share in the world of health, like solidarity. At the end of this webinar, we will be sharing with you a lot more details about more activities that we have planned out for this year. Today, we will cover a key point in the strategic agenda to achieve universal health and strengthening and transformation of the health systems. We've focused this webinar and we called it as Essential Functions in Public Health and Transformation of Health Systems. And we have now the presence of the attendance of a group of panelists that will be introduced in timely. Before continuing, let me tell you about some of the logistical aspects of our broadcast. We will be offering, or we are offering, simultaneous interpretation in the fourth languages of today's meeting: English, Spanish, Portuguese, and French.
Como el lenguaje de señas que pueden
And
ver.
as of for sign language, as you can see in the screen, please select the interpretation icon and select the language of your preference so you can enjoy today's broadcast. To choose the language, you need to click on the world icon in the bottom of your toolbar. And also, I'll suggest you to adjust the layout of your screen and put it in landscape mode so you can enjoy the
Pueden enviar sus comentarios.
presentation of our speakers. Take into account that you can write to us at any point of this webinar. Just do it so through the chat box. And finally, I would like to remind of our panelists here from the organization that we need to remain our mics off to enable the proper development of the meeting, and just activate your phone, your mic and your camera when you're going to participate and speak. Also, I'll ask you to speak slowly so interpreters can get all the information across. To kick it off this webinar, I will honor to open the mic to Dr. Marcos United, Subdirector of the Pan American Health Organization. Welcome, Dr. Espinar. Thank you very much for being here with us today. Let me open the mic for you. Thank you very much, Roberto. Good morning to everyone. Good afternoon. Some others maybe. Can you hear me, Roberto? A warm greeting for all of you from Washington, D.C. I'll speak in Spanish. And let me thank the Department of Health and systems of health for the invitation to let me open this important webinar or in seminar. Welcome everyone, like Roberto said, this is the fifth seminar, virtual seminar of PAHO about the essential functions of public health and transformation of health systems. For me, it's a great honor and a privilege to be here with you today. And I would like to thank all of you. And I see that we have over 200 attendees. We are over 250 at the moment. So I would like to thank all of you. I'd like to thank for your participation here because it shows your personal commitment that you all have with the development of public health in your countries. Also, especially and in behalf of our director, Dr. Etienne, we would like to thank to all of our speakers that will be sharing with us their experiences and their perspectives. During this important seminar, we will talk about the practice of public health, particularly, as Roberto said, the essential functions of public health and how does it influence in the growing process and transformation processes of health systems. At the same time, we'll talk about the experiences and lessons learned while implementing it in the countries of the region of the Americas, our beloved America. In the region of the Americas, we've foreseen a series of focuses, approaches, and pioneering tools to face the huge sanitary crises that have allowed us to reach important landmarks in our path towards health for everyone. It's been over 2 decades that we've been facing the weakness in the exercise of leadership in public health. But they decided to encourage a conceptual framework and methodological one of the essential functions of public health that was published by PAHO in the book known as Public Health in the Americas. Since then, many of our countries have used this tool and instrument to strengthen their own capacities related to public health. During the 59th directive board that took place in 2021, our member states approved the strategy to establish resilient health system and the recovery in the afterwards stage two are known COVID-19 pandemic with the means of keepsaking and achieving and keeping the achievements of public health. This contemplates within their strategic action the improvement of capacities in public health of our own countries, guided by the new conceptual framework and methodological framework of essential functions of public health, published by PAHO in 2020. This proposal explained in 2020 related to essential function of public health have been renewed, came and are born in an era of multiple challenges, and you know about it, as the re-emergency of infectious diseases, the epidemiological transition of our countries from the great work that they've done with transmittable diseases to new challenges such as non-transmissible diseases, such as cancer, cardiovascular diseases. The barriers of access to health services, the inequities in our region are huge. It is the most unequal region and inequitative region of the whole region, and environmental challenges also are related to health challenges. You know that any environmental problem will alter public health. Its course brings the re-emergence of it strongly, and amidst the last huge sanitary crisis of this century, as you know, COVID-19, we are already 3 years into it, and that has shown us how fragile and how vulnerable our health systems are. And to recover and rebuild it, to face future threats, and to protect adequately our population's health, it's of most important, the need of a collective response, wide, broad, wholesome, led by sanitary authorities of all societies and from all sectors, meaning we need of a bold and energetic response from public health. Our essential functions of public health that are renewed in a conceptual methodological framework with innovative tools offer the fundaments to strengthen the capacities of authorities in each country related to health and of societies for effective action from the public sector, and that will lead the transformation of health system that will contribute moving forward to our final goal, which is health for everyone. Let's not forget about that, for health for everyone. So far, we have 12 countries led by their authorities have started the exercise of assessment to strengthen the essential functions of public health that are renewed and are now in different stages. It's admirable to get to know that many of our countries have faced this path in a context that is so complex to consolidate their own capacities for the execution of actions in public health and to generate enough context to allow us to develop our sanitary systems better and provide an efficient response related to the different programs of health. At Bajo, we have a solid commitment with our country of cooperating and supporting the different initiatives and process for the recovery after the COVID-19 pandemic, what implicates the strengthening of its capacities in the development of the essential options of public health have been renewed. Finally, and not to take away much of your time, we hope that the discussion and reflections and takeaways of today can inspire us and motivate us for each and one of us to have different spaces to improve the scope of action in public health of our countries and to contribute with the awaited for strengthening and transformation of our sanitary systems. And as a consequence, with the protection of rights, health, and the well-being of each and one of us in the region of the Americas. Thank you very much for being here with us, and I wish you all an excellent virtual seminary. Thank you, Roberto, and let me give you the mic too. Thank you, Dr. Espinal. We really appreciate this adjusted vision of our route, of our path, and the guidelines of PAHO in this matter. Now we'll switch over to our first presentation of the day. Dr. Vasco, thank you very much, Roberto. Can you let me know if you can see me properly? I'll make a brief presentation. I see that we are surpassing already the 300 attendees, and as always, this will be increasing during the seminar. Can you hear me, right? Yes, we can hear you. Dr. Vasco, what I would like to do actually is to make a brief introduction of you. And I think that with that slide, we can just keep it there. But let me tell you all that Dr. Vasco is a regional consultant of governance and leadership in policies and verification of health of PAHO and WHO, and intervening chair of access and health of PAHO. He has a long career in public health, is doctor in social sciences with a post degree in governance. Let me welcome you, Ernesto, again, and you're leading this piece of work in the Americas. And that's how we no, please move forward, keep ahead with it. Thank you very much, Roberto. And actually, my presentation will be, in a way, a complementary one to the ideas that Dr. Marcos Pinal shared with all of us. The first element and the idea that we would like to put up in the table is that when we try to reflect on the relation between public health and processes of transformation for health systems. And the first element that I would like to emphasize is specifically a problematic reflection of this relationship, of the difficulties that the region has had into incorporating the component of public health in the agenda of strengthening of the health systems and transformation of the health system. In the middle of that recognition, where public health is in many cases aside or out of the political agenda and of institutional transformation of the health systems. And that's how we are, as Dr. Marcos Pinal mentioned before, what are the characteristics of this new framework of essential functions in public health? What he considered the essential functions in public health renewed with a new conceptual framework and methodological. And that's why, from the problematic of acknowledging that this is a challenge that we still have pending in the region, of thinking about making of processes of policies and the political processes of those transformational processes, the incorporation of key aspects of public health. Obviously, after what the pandemic has meant, the elements are newer, the challenges have been huge, and I believe that this is now the time to work with a greater strength, I could say. This discussion is so important to us. Now, the first point that I would like to emphasize is that if a characteristics will distinguish from this conceptual framework of essential functions that uh, far from being considered an intervention of collective action, the conceptual framework sheds light onto the capacities of health authorities, but not in an isolated manner, not in an autonomous, not alone or ostracized, but rather in conjunction with different associated stakeholders in the exercise about aspects that are critical for the functioning of health systems. And these are those capacities that are not just to reproduce the status quo of how our health systems work, but with capacities that are related to strengthening and to transforming institutional aspects, at least those that are the most important of the health system and from the health sector to cover health problems of the population. And of course, with the risk factors, with social factors as a key core part of our work. And the question is how? How this approach can or could have a potential of facing this type of element or this gap between these public health and transformational processes. The first one has to do with the definition itself of essential functions, thought as capacities, as skills of key stakeholders to improve the health system. But the second of all that I would like to emphasize, and this has been widely discussed, is the need of having a wholesome integrated approach. This magic in the territory, in the making of policies, and the technical cooperation of PAHO. And within this wholesome integrated cooperation, we need to also add up to key elements. The inclusion of individual services and collective services as a part of a whole agenda and not to fragment it in parallel agendas. And finally, to incorporate the element of social determinants that have a key approach. For example, when you uh, identify the structural characteristics and how divided it is in our region and the inequality structure in our countries where we have a social structure that affected the conditions of health and of life of a huge part of the population. We shouldn't think about transformational processes and improving the capacity of response to these problems if we are not incorporating the social determinant elements to it. And finally, I believe that it helps out to understand how this approach can could generate decisive steps towards incorporating public health in the transformational processes. Is this approach a conceptual one? Yes, but it's also a methodological one, where we are incorporating not just the institutional aspects and then the feasibility of generating action plans to strengthen those capacities, but feasibility, in fact, incorporating processes of making and implementation of policies, but also the political processes that are behind those transformational processes. What we see here is this landing of our focus or our approach of essential functions as a capacity, or where we include the leadership aspects of guidance of the health authorities as a key element to enable and to favor the transformation of the institutional arrangements that are the most important ones of the health system, covering, like I've mentioned, factors and the determinants as well. And the logic behind in this conceptual approach, of course, is explained in the processes of policy making. That in this conceptual framework is what I call the cycle of policies that start from the analysis of the evaluation of health problems and their causes, the capacities related to the development of initiatives and development of policies. Our third key element would be to incorporate in the agenda the need of understanding what are the critical resources that we need to include as a part of these initiatives and transformational processes, including not just technological resources or financial resources, but we also shed some light in the human resources as not just as a necessary condition, but as a fundamental subject of this transformational process. And finally, the access conditions. And like I also mentioned, not just incorporating this approach of collective interventions, including individual services and social determinants and factors. And this is within the exercise and the methodology itself that we are trying to put forward in countries, where we include an institutional analysis and, of course, also of the key stakeholders, landing it to the concept of each country. This is a key element, even not just when you are recognizing how specific each context is in regards of results, but also how can you adapt this analysis in function of the characteristics of the different sub-regions and the complexities of countries. And this allows us as well to recognize what are the most important challenges, even in the relation of leadership capacities that health authorities have to try and push and guide and articulate alliances with key stakeholders that have critical roles within their own health system. This is only a bit of an example, only where we are looking over countries and the capacity of influence that the health authorities have on different actors or stakeholders, depending on what's the type of stakeholder that we should influence in a strengthening of capacities type of program, if that's a part of a key part of the plan of the ministry. And we realize that the challenges are even greater when these stakeholders find a more decentralized space, in many cases related to critical roles in the management of health services, or when health services have a similar structure and capacity related to the segmentation of the health sector in regards to participation of social security and the private sector. And in the other hand, a huge or an immense and really important participation of different stakeholders that are located in more intersectorial type of spaces, I could say, where we require that type of broader look to the ministries of health, to health authorities, so we can articulate the agenda of these other stakeholders, so we can ensure the exercise of the essential functions in public health. But if there's something that I believe has stepped up or shed some light in the methodological type of work that we're doing is not just to link processes of analysis of institutional capacities and policy making, but also knowing to recognize how does these gaps influence the institutional capacity related to health problems of the population and the barriers of access to health services. This is a key element because the need of relating or linking institutional problems with the important problems of the population. And just to finish off, this exercise is adapted to really diverse conditions as we will see today. I don't want to get ahead of the presentations of my colleagues, but across the sub-regions in countries with different dimensions and complexities, we are not just moving forward participative processes, but I also think that it's fundamental to be articulated with the exercise of policy making of the countries themselves, and at the same time to adapt the tools to those same contexts. Thank you very much, Roberto, for this opportunity. Okay, Ernesto, thank you very much. I appreciate this strategic outlook towards the methodological tool. And of course, this is an important part for call towards change in the region. Now we'll continue moving forward and to open the experiences part of the presentations. We would like to look at public health in the transformational agenda and health systems. And first off, we have invited Dr. Pastor Castel Florin Sabat. Dr. Castel Florin Sabat is director of the National School of Public Health of Cuba. He is a doctor, a specialist in first and second degree in organization of administration of public health. He has a master's in administration of public health from the School of Public Health of Mexico and a PhD in health sciences from the Academy of Sciences of Cuba. And he was recognized by PAHO in 2016 with the Award of Administration of Health for his contributions to the Cuban health system and for his task in research, teaching, and its number articles and papers published internationally. Welcome, Dr. Castel. Let me give you the mic. Just let me remind you that we have only 10 minutes for each presentation. Please go ahead. Thank you very much for this possibility and the opportunity that you're giving us. It really has encouraged me to receive and to hear everyone before me. And this is an important part of this event for me. I have a technical difficulty. You need to open the presentation.
Vemos ahí aparentemente el lugar donde puede estar la presentación.
Ahí preparándonos acá para ir viendo.
Okay. Second, while we connect the presentation.
Esto. No hace falta ver, porque no se vea. Hay dos aquí. ¿Ven? Esto. Pero mira, no se ve. No. ¿La ven ahora, por favor?
Can you see the screen now? Yes, we can see it.
Pero creo que ya fueron resueltas las dificultades técnicas.
Apologies for these technical difficulties. Can you hear me? Can you hear me, please? Yes, doctor, go ahead, please. All right, apologies for the issue. Well, the role of health authorities and of public health in tackling determinants in healthcare is critical, and I will begin by saying that our presentation that is very brief, we will present conceptual and basic principles of public health. I believe it has been fundamental in our country with regards to conceptualizing very well what public health is, and in order to be able to act based on that. Well, public health care cannot be seen if we do not look to determinants or social determinants. I believe everyone is now aware that 70 to 80% of healthcare issues are in social determinants of health more than other issues. Therefore, aspects in with regards to policy, socioeconomics, and culture are fundamental. Therefore, people's life conditions, families, and social groups, we must address them as an extremely important element to achieve that physical, social, and mental well-being that we all know, which is always proposed as a fundamental concept in public healthcare. The text that I've written, I define it as comprehensive efforts from this government and society based on promoting, preventing, recovering, and developing health. And I define public health care as such independently of there being many definitions, because it is clear that public health is not a prop property of public of the public sector. If 70 to 80% of healthcare issues are in the environment or in society, therefore intersectorality in my research, and I've been showing that this must be all these factors must be addressed by healthcare and other sectors in society and economy. And we need to continue evolving to work with um, efficiently in all three aspects, because if we're talking about efficiency, we're talking about rationality. If we talk about effectiveness, it's about applying correctly, and also social impact. That is undoubtable that a level of integration must be there, and for this purpose, it is necessary to have participation from healthcare authorities, government authorities, and authorities from all other sectors in a comprehensive and integrative manner. Comprehensive because it has to do with curative and other aspects, but also because I define healthcare integrality in internal and external. Internal is among institutions, as we require for all institutions, and this is what we are prioritizing in Cuba. Internally, to have entities connected, a hospital with pediatric services, x-rays, laboratory, etc., and interinstitutional integration, which is a classical regionalization that we so much speak of, where each of the components of our country, there is a single healthcare system. Therefore, it is among those very institutions, but in any other, as in any other country, between state actors, aspects of society, and external aspects would have to do with the integration of healthcare sectors to other sectors in society. This way, we can achieve social promotion of healthcare, and this is where we can really speak of a network of systems and comprehensive healthcare system. Now, primary attention as a basic element in the healthcare system, we cannot tackle public health if we are not able to have primary attention continue being the support of healthcare systems. That 70 to 80% of healthcare issues, if not addressed with primary care, it will not be overcome at the hospital level. And the figures tell hospital may resolve 20 or 15% of issues, but the rest are in primary care. When hospitals fill up, it is because there's no sufficient primary care. That's a reality. Healthcare in all policies, because all sectors must be involved, and I believe it is very clear, and it is our conception that if governments and states do not participate in health and public health care, public issues will remain. That's a reality. The more government and state participation, more health issues will be resolved, and clinical management and community management, because not only can we speak of management at the level of our own assistential institutions, but also and everything that is done at the community level with significant participation. In our case, I believe that social participation is basic, but social participation is not discourse, but channeled. We have the possibility to have committees, federations, associations of farmers, which allow social planning that is comprehensive and then integrated fully to the healthcare system under the government's hierarchy. That's also a reality. And follow-up and evaluation as such, and essential duties of public health care, we have proposed that it must not be and remain only at the level of officials who perform sanitation or healthcare practices. This must transcend into training elements from preschool. We have a great opportunity for institutions that training are part of the healthcare administration. As such, we determine teaching that is provided based on the needs of healthcare promotion. But if we do not introduce in oh in graduate and postgraduate, not preschool, this aspect, it will be very hard to take this to practice. Therefore, with regards to conceptualizing public healthcare, training of human resources is part of all spaces. There are spaces of full action where paradigms for acting change. We cannot continue advocating under the paradigm of disease. We must go for the paradigm of health, as we cannot act and think and act at the level of the sick individual when that it is about having an MRI or an ultrasound. We must tackle health issues with health perspective and many more actions that complement it via technology, and the cost undoubtedly is much less. Therefore, the paradigm of disease must go through predominantly into a paradigm of health, and this will have models of attention changing and times of attention will be diminished so that the millions of dollars spent in healthcare around the world, this must change. Healthcare is unattainable if we do not address issues from primary attention and from the problems of the social determinants of health. And another element we wanted to highlight is regarding our experience, because I only have 10 minutes in human rights in our own country as social value, social promotion of healthcare that should highlight integrative social policy into government. Here, when COVID came in, we eliminated it as it is known because of the level of integration of the government with the healthcare system and biotechnology, where every day we analyze not only the healthcare sector, but the chair of the republic with all of the state's apparatuses and technology which was put in motion based on the needs, which is why we say that intersectoriality is fundamental. And here on screen, this is on intersectoriality, analyzing healthcare surveillance, and social participation. And these are technologies that are proper to public healthcare, which should not be technologies linked to the paradigm of disease. The strategy for primary healthcare attention is to strengthen primary level, which is one of our purposes, and healthcare services in universality, fundamental indicators of social effectiveness, and our own indicators. Although we had an effect by the pandemic, which I believe has been well analyzed, but it maintains, oh, we've had the lowest child mortality around the world. Preparation of our human capital in graduate and postgraduate levels. Ever since people are students, when they are specialists, we must not get them thinking They must be able to know the problems in each family, whether they're cooking with a lot of salt and too little salt, and other elements that are from social healthcare that should be properly addressed and worked on universally by the population. This is the comment that I want to present in only 10 minutes. I would have liked to expand or elaborate much more, but it is impossible. Thank you so much.
Muchas gracias, doctor Castelfleurit.
Thank you so much, Doctor. Very interesting your presentation.
La acción de los gobiernos en esto es tan fundamental.
Public health care and the action of governments is so fundamental currently, and the risk that remains so clear after the pandemic. There are lessons on technology that came up, but also with community and model for primary care, which is so strong precisely in Cuba. So I thank you for your presentation. I would only like to mention that two things, that you may start forwarding your questions in the Q&A section, and by the end of the session, we'll have space for our guests to present questions to have them answered. And I can tell you that we are now around 400 attendees to this webinar, which is very important to the Americas. Now, to share other experiences in tackling public health care and strengthening public healthcare systems, we have now invited Dr. Lucy Lopez. Dr. Lopez is the head of the preventive medicine and healthcare department for the School of Medicine of the National University of San Marcos in Peru. She is an OBGYN doctor with a postgraduate degree in Great Britain on strategic healthcare. She has more than 5 years experience working in many locations throughout Peru and remote locations and the capital of Lima. Thank you for being with us, Dr. Lopez. And the floor is yours. Please go ahead. Thank you so much for the invitation. We are very committed with the issue of strengthening healthcare systems, and in particular, in this case, as Dr. Pastor Castel has mentioned, what is on us, universities, is to train the professionals that will be implementing public health care. So here, the first thing we would have to mention is that the National University of San Marcos, where I work, comprises in its statutes among the goals of education precisely what we have just mentioned, and it is that it must create, assimilate the student critically to preserve and convey knowledge in all fields of science, and the university has as a goal to train professionals and researchers based on a critical foundation, also humanistic and ethical one that allows them to operate with responsibility and creativity. When we speak in particular of the Professional School of Human Medicine, in the graduate profile, or actually in the profile for students, it describes the way in which students arrive, but after having gone through core studies. So we have this core phase when there's basic training focused on values and scientifical, humanistic, philosophical, and other foundations, and in the capacity to apply principles and theories related to healthcare sciences, employing their innovative, entrepreneurial, and ethical attitude. So this is a continuum after students are admitted into the career of core curriculum. So ever since they begin primary or basic education, and when students graduate, the profile that is sought after is for an individual with a solid technical, scientific foundation with a humanistical perspective and innovation that learns on an ongoing basis, assumes leadership, investigates, and works in interdisciplinary teams for attending to comprehensive health to individuals, families, and communities in different situations in the country, with an emphasis on the strategy of our primary healthcare attention, the promotion, prevention, and attention of prevalent health issues. So we now have the framework, institutional framework for operating, and then we have the way and the need for looking how we are to implement it. And obviously, the university, we locate ourselves in the minimum angle below healthcare services, but we need to see immediately that to speak about public healthcare, our students must consider immediately the physical conditions such as age, gender, the life stage of people apart from lifestyles and environmental conditions. If since the first day they do not consider that an individual is all of this, and healthcare services are only a part of resolving healthcare issues, then we will not attain what we have been assuming as a lesson learned during the pandemic. We properly located in the chart the need to have healthcare staff which is competent in the field, but also for them to comply to public healthcare duties, as we can see on the other end of the disc, and in the middle, community involvement. And this is central because it will entail a paradigm shift. It already means a paradigm shift in the way in which we have been educating people, healthcare professionals, where the individual is not at the center as subject of the final action of healthcare. And also, during the pandemic, we've learned that those countries that have better developed their response have been those that are already accustomed to working under interinstitutional, intersectorial collaboration at every level within countries as part of carrying out their healthcare system duties. And here we must look to what we conceive as public healthcare. This is the science and art for preventing disease, to prolong life, and to promote health through organized efforts in society. It transcends what we can be doing in the healthcare field, and obviously it entails social, economical, political factors, as well as healthcare services, as well as collective actions and decisions. Obviously, indicators for public health, we can see them here. This is the life expectancy for mapped for Peru from 1915 to 2019, and undoubtedly it has increased. And we can also say that in healthcare impact in the country can be measured via the reduction of child mortality. However, we are aware in Peru that these averages include huge inequalities, because today we could have native or Amazonic communities where life expectancy upon birth continues being around 48 to 50 years of age, as we have seen in the latest study in Amazon communities of the four basins of the Loreto region. So it is true that public health care has an impact. However, it does not have an homogeneous impact throughout the country. And this is a highly important factor that we considered in designing interventions. When we speak then about the goal of public health care in teaching, we would like for graduate and postgraduate students to be able to develop with efficiency to contribute to a working healthcare system. And the strategy for primary health attention, we must adapt it, because as we are saying, it is too focused on the second element that is proposed here, which is healthcare service, global, ongoing, comprehensive, effective, and efficient, distributive, equitably. But at this time, it seems it is the only component of the primary healthcare attention strategy when we speak about the strategy, without leaving space for multi-causal treatment of public of health issues. And for this purpose, we need to see that in our country is too diverse and too unequal, and so multi-causal um, addressing of health issues will have to have many stakeholders in every locality. Our school at the San Marcos University in the Department for Public and Preventive Health provides courses to 5 professions. To the left, human medicine, nursing, OBGYN, nutrition, and medical technology. And we also have, in the ways in which we apply this intervention in core studies, we have students that come from basic education into these 5 professions with an average of 700 students that are grouped on average in 30 to 32 per class, but in a grouped manner. We have the 5 professions included. So we provide on an annual basis in the Department of Preventive of Public Health Care 50 courses per year for all of these careers. And in addition to that, we are responsible for internship in medicine at first level, which is responsible for applying the health strategies in first level facilities in the country, but in Lima, which is where we train. Only as an illustration, I would like to mention to you that what we began, or the line for training on public healthcare and core studies, we are focused much in debating with the students where we are speaking of a human person and a biopsychosocial unit. We will see how in the application of interventions and in the guide for every educational session, we will be emphasizing how we highlight this comprehension of what they themselves are and therefore the others, and what it entails saying that every person is a biopsychosocial unit, and tending to that person under that conception must be handled. Obviously, the other important issue is the difference being between public health, populational health, as it is also called in some research, and how it is based on advancements in management of individual health. So the link between the two, and why? Because we seek from the beginning for students to have embracing public health to the measure that they advance their practice in basic sciences and clinical sciences. And obviously, from the first day upon admission, we need to look to the reason why we're so interested at this time, which is having health exist as a right for all citizens, and how society can organize, and how it is that public healthcare is an instrument for this purpose. And obviously, from the first moment, to see that the cause of causes by the articulation of social determinants must first be identified in order to act based on that. Another important thing from general studies is that, however, it's true that we are growing these 3 types of knowing: the knowing how to do, and the knowing how to be, and the knowing we privilege in this case at the beginning in the training stage, the knowing to be. The knowing to be, because that will be in core studies the foundation, the scaffolding through which new knowledge throughout their whole life they will have to be built. And if it's not done so with due comprehension upon the first time of their admission, they will have no anchorage. And they need to notice that from the first day as professionals, there will be one day when they will be alone in their decisions. And if they have not properly done this foundation of knowing how to be, they will probably not have the not embrace people as to facilitate their decisions. And obviously, teamwork via discipline by integrating them into groups in each of the classes ever since core studies. Now in Peru, we have many Perus, and the performance of the youth will have to be specific in every territory, depending on social determinants. And however, to have a common denominator of actions that will have to be developed by all professionals in healthcare, there is a need to develop also transdisciplinary efforts, as I say, beginning ever since core studies. One very important thing that we emphasize also since the beginning and in line in training is that health is in the hands of the individual. As we saw with the assessment of healthcare systems which have responded better in the pandemic, have been the countries that have been focused on action and participation of individuals? And in what way does the population participate apart from analysis in general through this issue via the healthcare system, which is called self-assistant and is based on information that must arrive through organization of the healthcare system and which goes along the everyday lives of people, because finally it will be the individual who will adopt the final behavior for caring for their family and their community. So this is a clear example of how interdiscipline can have an impact on a fundamental issue in public health. In the Department of Preventive Medicine, this is the kind of courses we provide. The first three are core studies, and the others, epidemiology, the history of health, medicine, family, and community, statistical analysis are from human medicine, courses for nursing, obstetricians, for medical technology, and for pharmacy and biochemistry, and the School of Nutrition. So we have 24 courses through which this concept that I have been telling you about will be conveyed in the way that I will tell you next. Obviously, in summary, that is plotted into these basic duties of public healthcare ever since addressing that social determinants and participation, surveillance, and monitoring. It is all encompassed. So this chart summarizes pretty well everything that the professional healthcare team must do or know how to do, and as we've said, must be in order to implement it. The issue that we will briefly tell in the minutes that I have remaining is how we are implementing it. So here we have the curriculum. At the university, as you know, we handle ourselves or based on curriculum. And so the academic year for course studies encompasses 2 semesters where we train in humanistic personal training sciences and their application to into health sciences, and strategies for learning in higher university education, which is the first semester by which we admit students coming in from basic education in order to train them in learning in university education. And in the second semester, we have these courses on social identity, culture, and participatory disciplines, language and communication, and cultural manifestations, art, and sports. So really, in Peru, well, there are other courses as well in core studies, but these that I have mentioned are those that are the duty of our department. In Peru, students graduate with only 5 years of secondary education or high school. So they are younger than the average comparing to countries in the region. And many years ago, San Marcos proposed the need for there to be this space of core studies in order to fulfill and turn that physiological and anatomical maturity so that it goes along also with the mental organization of students that are very early in life to begin university studies. So these core studies fulfill both ends, and so we set the foundations of public healthcare training here. We will take the example of one of the courses, which is the way in which we are proposing the introduction of teaching in public health. In this family medicine and community syllabus, we have units, and the unit, for example, in this case, for this course is a theoretical and methodological framework on medicine and health. And the second unit, interventions for caring for the individual, family, and community. And in the third, this is the model of comprehensive health care. So units are more or less of 4 or 5 sessions, each with its own guide that helps us to set activities by which we do the reflections and the analyses and the syntheses for practice. So the way in which we have organized, for instance, this is a session guide for one of the sessions, which is on identifying health priorities, social stakeholders, and the working plan. So this session in particular, each of the sessions in the course of Medicine and Family and Community has a special session guide. It holds results, expected outcomes for each session,
of identifying the social actors and for each and one of the results. We have identified, as you can see in the lower part, for each of the results, to value these opportunities we give in the analysis, even though they're young people that just coming into here from public education. We show them the capacities sheet center for epidemiological week 12 in this year 2022, where we have a national outbreak of, well, in some regions at least, of dengue. And we read out the crisis in the crisis room as an analysis element to comply with the result of learning of the session and takeaways. And at the same time, for the mapping and for the working plan, we give them a series of resources. It could be through YouTube videos or reading material. And for the critical analysis, for example, in this case, we've chosen the Legacy of Almata, which is a really important article from Marcos Cueto, to be able to answer to the question, how can it be possible to achieve in our country the participation of the local stakeholders in the prevention and control of dengue? Assuming a concrete thing they're looking at in the media. And finally, the students, in this case, in a virtual session, they do the analysis on how has it been growing since 2016 and the differences between, or comparing it to the previous year. And whatever they can do, taking into account the participation of the community as a main core axle and all the other elements that we have also mentioned. What are the challenges that we have in this scenario, in this current scenario? First off, we're starting from the point that we need to link and relate between what's supplied in our work in the academia related to public health and the help. We need to have a relation between supply and demand. We need to place enough importance onto the things that we are doing in the foreign market, and also training wise in the pre-degree we have a great demand. The preferences of the complex specialties and technical specialties of individual health and not the competencies or skills for populational health. And in the other hand, students understand that how are they going to have to choose between their schedules and their working load. And this preference is noticed by students. And now we're working on this matter because they need to understand that there are more things more important than information. They need to round out that work, but the critical context, such as the pandemic, creates a sense of urgency and becomes an opportunity to develop skills in public health in this case that we shouldn't put aside, just as what happened with COVID in Peru, particularly where we've been affected. We have 250,000 people that have died during this period of time, and many households have been broken mental health wise, insecurity, and all the things that are around this process. Another thing that we found in the process was the international accreditation of the medicine school that we are representing, where we are going to evaluate these three areas: biomedical, clinical, and social, medical, and humanistic, as a part of the implementation of public health and the functions of the public health that we're talking about. And that we consider that immediate strategy would be to encourage the instruments of public health in the session guides and especially for our session guides with the results of each session in the resources that we've presented in each session of each of the topics. This is the opportunity for it. So this will be an immediate strategy within the curriculum of our project because we are not planning on changing it as much. This is a process that's given during the evaluation every 3 or 4 years. So even with that strategy of immediate implementation, with all of that and everything that we're facing, what we have to do is to build a line of work from general studies or maybe the second year, the third year, with the opportunities that we can find in the courses where we can input these session guides or the use of these instruments. And additionally, to build a line of work in training in public health alongside each career. Thank you very much. Thank you very much, Dr. Lopez. You have shown us a vision from your own perspective and from San Marcos University related to public health. Rescuing how important it is, this point of view of human resources as a part, as a fundamental part of transformation to improve our public health in the region. Thank you very much. Our next speaker is Dr. Luis Facchini from Brazil. Dr. Facchini is a main researcher from Federal University of Pelonas. Dr. Facchini is a licensed in medicine by the University of Santa Maria and has a PhD from the Autonomous University of Xochimilco, Mexico, and a PhD in medicine by the University of Rio Grande do Sul. He has a PhD in international health from the Harvard University in the US. And I shouldn't let slide the opportunity to mention that he's been a really important partner in the development of the analysis for strategies in public health of Brazil. So thank you very much for accepting our invitation, Dr. Facchini, and please go ahead.
Gracias, Roberto. Gracias a todos. Bom dia, buenos días, good morning. Voy a hacer la presentación. Sí, se la ve, está bien.
You see it?
Bueno, gracias. Voy a hablar en portugués y toda la presentación está
Well,
ahí.
speaking Portuguese and the whole presentation is in Portuguese, so
Acompañar con la traducción.
you can use your interpretation
Nós
service.
vamos apresentar hoje a
Today, we will be presenting the adaptation to the Brazilian health system of the essential health functions renewed for the 21st century. This is some work that we've been doing in cooperation with the PEJO, laid under the leadership of Roberto Tapia, with Fernando Leles and an important team that works with us in this effort, which has been a very concentrated effort, which has been ongoing since August 2022 to adapt and especially the instrument of analysis of institutional capacities in the Brazilian single health system. Many of the people on this slide are my colleagues from the Federal University of Pelotas, other universities who have come together for this work during these very intensive 4 months of work. The project, its objectives is to analyze the applicability of the methodology and the instrument of institutional capacity analysis proposed by PEJO and WHO for the renewed PHC in view of the special characteristics of the Brazilian SUS, Soul Health system. We also record and reflect on Brazil's experience in the application and use of FESP as a mechanism for strengthening the SUS. We also designed a methodology to adapt the FESP to the context of the Brazilian SUS, which integrates and strengthens its priorities, considering the legal basis, information systems, methodologies, instruments, and all of the information and results which are available in Brazil. And we also organize the application in some chosen territories, states, and municipalities of this methodology to assess its adherence to the needs, realities, and peculiarities of the Brazilian healthcare system. This activity was begun on September 21 in the Pan American Health Organization seminar in Brazil. We had several colleagues with us, including colleagues from the Brazilian Brasco and the PEJO from Washington. On September 12, 2022, there was a strong emphasis on state level secretary departments and public schools throughout Brazil. This process, it has opened the adaptation of this instrument, of the renewed EPHF instrument in our country, in the second time around trying to adapt it. And we had a series of activities. We started off with a document and literature reviewed, and we interviewed key players which were part of the first adaptation. And this has helped us organize and systematize the available information, such as what was mentioned here today when Ernesto Bascolo described the theoretical basis of the essential functions of public health, to establish these functions as indispensable features of health systems, services, practices, routines, and established rules in response to the health needs of populations and territories. These functions are attributes of the management of such health systems, and they allow us to determine where we are, how we are going, what we've already done, what remains to be done, how to understand the situation we are in, how to measure and understand it, which are the best understandings and measurements and functions, and what are the intervention plans which can be designed from assessing the healthcare system essential functions. For Brazil, in fact, the challenges in characterization of PSHEF in Brazil is fine-tuning with the SUS principles, and therefore, which are the guidelines that are needed to adapt. So we split that up in three very important issues. First of all, the legal basis. Second, the installed capacity. And thirdly, the institutional processes, which make these things the principles of the SUS come true. The doctrinal systems that allowed the SUS to be universal, that is, guarantee the right to health to every person in the Brazilian territory, and that it be integral, reaching all of the healthcare needs of the population and all of its demands, and still that it be equitable, to ensure an adequate answer to the needs of every single person, and thusly avoiding inequality, injustice in these services, of delivering these services. We also speak about the organizational aspects, which are characterized by its regionalization and its hierarchy in a network of healthcare, decentralization for healthcare delivery in municipalities and other places, and social participation with highlighting the control of the population and their deliberations, their decisions of which initiatives should be offered to the population. Therefore, this adaptation has helped us identify a group of elements from the legal backgrounds, from the Federal Constitution of 1988, which speaks about healthcare within the sphere of social security in the countries, and says that health is a right and that it does not depend on direct financial contribution by the user where they are using the services. And the group of rules and norms and laws regarding the organization of the system, primary attention, human resources, financing, assessment, and delivery. Right now, we are in the perspective of beginning 2023 with a new government led by President Lula, which reinforces this perspective of the historical and social basis of our SUS. Because of the great problems and backlog we went through in the last government, which attacked all of the social and healthcare rights of the Brazilian population in the last 44 years of this government. We also want to review the history of the adaptation of essential functions in Brazil, which was originally published in the document by the National Council of Social Departments in 1997, and then was followed by an interview of key players from the first adaptation, especially Professor Fernando Cupertino from CONAS, Rita Catanelli from CONAS, and Julio Soares, who was in the technical unit belonging to PEJO, and all of them highlighted the importance of a participative process in our country. After a critical analysis and translation of the unit instrument, we moved on to workshops with SUS, the single healthcare system in Brazil, technicians and managers to deepen, to strengthen the knowledge we have of each FESP instrument. We also had the opportunity of working with PEJO WDC in Washington, and all of the efforts of understanding how to apply these essential functions. These was very important moments of interaction. And then we reached the workshops itself. We had online workshops. We had a workshop in Salvador, Bahia during the 13th Brazilian meeting of collective healthcare. These workshops helped us not only present the proposal for essential functions, but determine in tandem which are the essential functions that are important for our work. We determined about 20 work groups to work on these functions, and we created 4 groups. For one pertaining to the cycle of politics, to articulate the integration of these issues, always discussing its applicability to SUS in Brazil, the year of government, it will be applied. If there any adaptations are needed to the way it was written, and the proposals and suggestions to make it actually work out. This was done very quickly, considerably the time we had. And lastly, we closed off this group of activities in the Abrasco workshop. We ran a pilot test in Bahia. We just wrapped it up in 6 and 7 December. It's very recent. Uh, we were in 2 days working very hard over there, working 2 days in two different locations, reviewed all of the questions about the instrument of instrumental capacities. We resumed the analysis of the conceptual structure of the instrument, detailing the metrics that were used, and we made a balance of the questions according to the classification of the TWG participants, questions that apply to the SUS by scope of government. We saw adjustments in the wordings and the region for exclusion of questions that do not apply to the SUS. It was a very participative process. Hundreds of people took part in these activities, looking at the different uh, important public healthcare directives. And as you can say, each participant made its own contribution to make sure that we had an adequate version of this document that contemplated the different contexts of SUS, whether it be federal, state, or municipality context. And now we are going to wrap up this adaptation this week that begins now in September 12th in the city of Vitória, in the state of Espírito Santo, where we will be speaking about state and the municipal department of Vitória, which is the state capital. And by doing so, the analysis of the EPHF instrument helped us understand the overall number of issues. We looked at the number of issues, its subdivisions. We moved forwards in proposals according to aspects which might be strengthened, such as environmental and worker health, and also adds what we are calling a 12th social public social proposals, which is the regionalization, which is very important for our country. It must be very strongly developed in our country. The logical structure of the instrument is very robust. The capacities have been determined, the areas for interventions, the contents, and the questions, which are detailedly analyzed by the participants, identifying the bottlenecks in which there is a total absence of the contents or reference standard for the action plan. Here we see an example of one of the functions, which is monitoring and evaluation. And in the 5 areas of intervention, for this, we have 5 areas of intervention, 27 contents, 349 questions, as we can see on the box in the right. Of course, we have a spreadsheet. It's very small here. It's hard to see, but we can see that the instrument adapted to a spreadsheet is presented to the participants and it is discussed. So we have the question in Spanish, its translation in Spanish, and its adaptation based on discussion with the participants, indicating its importance to this SUS, the importance of its application, and the eventual need of any changes to solve and wrap up the task. Wrapping up the discussion, we spoke to all of the participants about the importance of the country's political, healthcare, and social context since 2016, because we need to adapt this instrument. The booth does not have any sound. So the last government, the current government, was since 2016 was a rupture of context, problem, and then the current federal government, which made several problems and really hurt the healthcare system, and we moved back very much with this current federal administration, which damaged our healthcare system. So we needed to qualify the adaptation of the instruments. The questions reflect patterns and values which are expected in current situations for the healthcare systems. And the observations, criticisms, and suggestions were very important to adapt it. Overall, we moved forward very strongly from the first moment we started using it from 2003 to 2007. At that time, the National Board of Health, the state health care departments that led this process. And it's important for us that we did not have until now, but from next year on, we will have. There was no version in Portuguese because we need an electronic instrument to fully use this instrument in the Americas, in Brazil, and also to organize an online course, which will be very important for application of these issues for our country. So it is noteworthy that the new proposal does not have a Portuguese version, especially for the electronic tool and the online course, and the translation and adaptation of the instrument into Portuguese will be a great stimulus for the full use of the FESP proposal in the Brazilian healthcare system, the SUS. Thank you very much, and I am at your disposal.
Okay, doctor, thank you very much for the presentation. I would like to say that this experience of development, and this is developed in Brazil. And that makes us understand that we also need to be guided by previous experiences that are gathered and that we share across the country. And that actually makes our strategy move forward quite a lot.
Vamos a avanzar ahora a la segunda parte.
We'll now move forward to our second part of the webinar. I'll ask the speakers to move forward because we're really adjusted with our time. We have 4 presentations and we are still within our timing. I'd just like to say that I would like to invite everyone to the Latin American Lab of Participation in Health, an initiative of Brazil from the National Council of Health and from PAHO's office in Brazil. The lab has an objective of contributing to the efficient system and to get all the successful experiences known of participation on public policies and the development of public health. We will ask you, invite you to share your experiences from all Latin America and Caribbean. To have an institutional involving or not necessarily, but we'll select 20 experiences and we will be sharing these experiences in our website. You can find the web or the site's web address on the chat box. And we'll now go to the second part of the webinar where we will look at more specific experiences of countries for important transformation and explaining of the health systems. We'd like to invite Dr. Philip Plant. Dr. Plant, that's an administrator of the public health system. He has a master's in public health of this with our broad experiences working in hospitality sectors with the Ministry of Health of Bahamas and for prevention of diseases in the America and then the Caribbean region. Welcome, Dr. Schwan. Let me give you the floor now, and let me remind you that we also have only a few minutes, and let's try to stick to our timing. Thank you very much.
Good morning. Thank you for extending this great honor to the Bahamas to be a part of this webinar.
Buenos días, tengo el honor de ser parte de este webinar. Quisiera agradecer por eso.
Right. Sorry about that. These series provide a greater understanding of how public health systems can be comprehensively evaluated and present strategic avenues for strengthening in a sustainable and prioritized manner. Chapter 2 of the World Health Organization's online publication, A Healthy Return Investment Case for Sustainably Financed WHO, states that the COVID-19 pandemic is the most extreme combined health and economic crisis in the last century. In the Bahamian context, as of yesterday, the 8th of December, the Ministry of Health and Wellness has recorded more than 37,500 positive cases and 833 COVID-related deaths, and has characterized 4 to 5 waves of the pandemic. We have had days when we have had overwhelming numbers of hospitalized patients. We've had lockdowns, health systems' ability to respond stretched beyond capacity due to illnesses among healthcare workers, and a post-pandemic exodus of skilled nursing and physician staff. The indirect health impacts of COVID-19 have been manifested in disruptions of livelihood, education, and social protection. But the true test of a country's public health systems mettle is measured not only in its weathering of the storm, but how well it responds and builds back better. This presentation will seek to categorize the experience of the Bahamian health system in 2 categories: preparedness challenges and successes during the response. The Essential Public Health Functions in the Americas document posits that public health is the practice and field of knowledge of collective action in which the state, together with civil society, protects and improves the health of the population and guarantees the population's right to health. It further recommends the expansion of core functions of public health to 4 stages: assessment, policy development, resource allocation, and access. As we examined the so-called preparedness challenge, I will use an excerpt from a discussion paper published by the National Academy of Medicine entitled Public Health, COVID-19 Impact Assessment, Lessons Learned and Compelling Needs by DeSalvo, Hughes, Bassett, et al. To discuss the preparedness challenges juxtaposed with the 4 EPH stages of assessment, policy development, resource allocation, and access. The first area is that of workforce. The aspects of the workforce that prove to be a challenge include retention and recruitment, along with the ideas of limited bandwidth and 21st century skills. Workforce is aligned with the EPHF stage of resource allocation. In this context, retention and recruitment speak of skilled healthcare workers. During the early days of the pandemic, this referred to the availability of nurses, physicians, imaging technicians, respiratory therapists, and laboratory staff. Also during the pandemic, and even more so in the aftermath, it highlighted the migration of skilled workers, intensive care and other specialty trained nurses, especially, as well as physicians and respiratory therapists, to be employed in other countries. Limited bandwidth. This, though critical at the time, the previous listed categories of staff were not sufficient to manage the response to the pandemic. Gaps in the response were soon appreciated to be unable to be met by clinical care providers. Thus, there was a need to expand the bandwidth of understanding of what skills were required for a properly functioning health system and pandemic response. Thankfully, there was an immediate response to the recognition of this need to bring to the table health planners, data analysts, statisticians, computer programmers, health policy specialists, behavior change specialists, communication experts, and lawyers. 21st century skills. Even in this post-prolonged pandemic phase, there is still a need for the health system to recognize or acknowledge the role of 21st century skills, including social media managers and contact tracers. These groups can be used not only for infectious disease control, but for defaulters of other population health programs, such as immunization, child health, hypertension, and diabetes, among others. There is also the challenge of not recognizing and accommodating the skills of individuals who may not have formal training in an area of public health, but who have demonstrated crucial competence in areas of public health management during the pandemic. The elitist posture of clinical medicine has slipped into the practice of public health, further exacerbating the involvement and inclusion or exclusion of skills in the available workforce and meeting the public health response needs. The foundation. This is aligned with the EPH stages of assessment, policy development, and to some extent, access. Weakness in the foundation is a result of underfunding of core public health capabilities and programs. Traditionally, what has been termed public health services in the Bahamas has received less than 15% of the budget of tertiary health institutions. That budget has then to be further shared with the management of primary healthcare services so that the effective investment in core public health functions is actually much less. Most impacted by this under-resourcing is the ability to improve and develop a stronger, more robust health surveillance program, starting with communicable diseases. As we build back better, there has been a recognition of the need to strengthen mechanisms and systems to maximize the utility of syndromic surveillance, such as the use of artificial intelligence, big data, and analytical technology. Additionally, there is a need to ensure targeted support for public health teams, the workforce, and researchers. Surveillance systems for communicable diseases would also be strengthened through the use of contemporary data sciences, reliable and valid random testing to strengthen infectious disease surveillance, and short-term and long-term investments in adequate laboratory infrastructure to support the potential expansion of both the scope and magnitude of testing. Additionally, significant investment has been earmarked with planning underway for the implementation of the requisite information technology to minimize duplication of efforts and to connect disparate health and other relevant information systems. Insufficient resources and mechanisms and policies to maintain cross-sector relationships. Another gap is the absence of enduring relationships with partners that support the social determinants of health, such as social services and education. At present, these connections are still transactional and based on personal relationships. These relationships must be institutionalized to have a greater impact on policy formulation that will benefit health and population outcomes and improve the relevance of assessment reports on the status of the health of the population and indication of improved health metrics. Technology, gaps in funding and low support have been a persistent challenge. The pandemic highlighted the matters associated with chronic gaps in funding and support, not only in the public health sector, but also in primary health and tertiary level health systems. Existing health information systems were not robust enough to provide the level and amount of detailed information required. Workarounds were heavily dependent on human-driven mechanisms. Secondly, the health information infrastructure was outdated and unable to meet communication needs. Partnerships, however, with both telecommunication companies were instrumental in erasing the deficits of connectivity through the immediate supply of telephone instruments, cellular data, and airtime at no cost to the ministry to support contact tracing and other communication needs. The lack of interoperability remains a challenge, but having been identified as a crucial issue, steps are far progressed to resolve this issue among publicly funded institutions in the first instance, with a view of beginning to have parallel solutions for willing private sector partners as the interoperability platform develops. This relationship also extends to the inclusion of social and education partners, where data parameters across systems highlight the indicators for poor health outcomes and provide an opportunity to address them. Emergency preparedness. It has been said that emergency preparedness has been progressed at the pace of boom and bust cycles. Unfortunately for the Bahamas, the booms have been occurring with increasing frequency over the past decade. Boom refers to the actual impact of a disaster situation, and as this is when attention and in some cases funding is made available. As we sit here today, the Bahamas has conceptualized a wide-reaching disaster preparedness program, which is expected to take greater shape in the coming months with the establishment of a static health disaster preparedness mitigation and response team and a center of excellence aligned with the global network of centers of excellence in disaster medicine. Successes during the response include.
Dr. Swan, let me tell you that we are near the end of time. If you can conclude in a couple of minutes, it will be great.
Pardon me?
I am only saying that we are near the end of time, and if you can conclude in a couple of minutes, it will be great.
Yes, I can. Successes during the response include data surveillance systems to support data collection and analysis, vaccinations in terms of access to vaccines, mental health, existing strategies were advanced to mitigate the negative impact of poor mental health, initially among healthcare workers, and later through national hotlines in 2 languages, and community engagements. These civil society networks were instrumental in encouraging earlier vaccine administration success as advocates among their families and circles of influence. As we build back better and fully engage the essential health functions to expand and strengthen the capacity of the health system to support the health of individuals and populations, we endorse the words of Paget et al. In the article entitled COVID-19, What We Have Learned, What Are the Public Health Challenges, published in the European Journal of Public Health, November 2021. Public health is the cornerstone of a functioning and healthy society and should play a role in future planning. Ladies and gentlemen, thank you for your attention.
Many thanks. Muchas gracias, Dr. Schwan.
Thank you so much, Dr. Schwan. I believe Dr. Schwan's presentation has been very interesting in telling very in simple terms on a strategy for addressing and healthcare systems organization before the pandemic, and how there is a clear mission to continue furthering these issues, which are so important in the arena of strategic issues in public healthcare management. Thank you so much. And next, we will hand the floor to Dr. Apologies, we have a change here in our agenda. Excuse me. Dr. Akichara from Suriname, who will present on behalf of the Ministry of Health, Suriname. I will ask, please, that he shares his presentation. We remind you, you have 10 minutes to finish, and please go ahead, as we're very interested in this presentation. Thank you so much.
Thank you, Doctor. Good day, everybody. Apologies, Doctor, the director could not make it, so I'm presenting on behalf of the Director of Health. A quick overview of the process that was done for Suriname. Suriname is one of the first countries in the region of the Americas to complete the essential public health function evaluation. And this evaluation started in June 2021 with the help and the guidance of the PAHO. The exercise was done in 2 phases. The phase 1, the first phase, was a comprehensive situation analysis on the health systems in Suriname. And the second phase was more focused on the measurement of the institutional capacities of these 11 functions in Suriname against the standards for each of the functions. And a gap analysis was conducted, and an action plan was developed to fill the gaps. With regards to the policy plan of the Minister of Health, 2021 to 2025, the vision is to guarantee access to quality of care, and 2 main policy areas are: 1, the prevention and reduction of the morbidity and the mortality, and the second one, the availability and accessibility of quality health care for the entire population. Here you can see the key objectives of the policy plan that were aligned with which are aligned with the 11 public health, the essential public health functions. At the moment, the health sector is undergoing some reform, and that is that's currently, and can see that the reform plan started after the COVID pandemic. And the plan consists of 9 programs. They are listed here. The first one is more the social security insurance. The second one is the funding and efficiency of the inpatient care. The third program regards prevention and health promotion. Fourth one is the modernization of remuneration structure and training in healthcare. We have the 5th program on modernization of medical inspection and the continuity of care. The 6th program under the reform plan is the modernization of the primary health care, a very important component. The 7th one is the improvement of the pharmaceutical support. The 8th program regards the modernization of healthcare and technology. And the 9th one is the establishment of the public health authority in Suriname. The 11 public health, essential public health functions that the evaluation was based on, those are listed here. And here you can see these are, in this slide you can see the results of the evaluation. The areas highlighted in green are where we are doing okay. Of course, more can be done. And area 3, the areas that are highlighted in red, that are research and knowledge management, and the area 8, efficient and equitable health financing. In those areas, we need, I think, major improvements. Yes. Looking at the use of the essential public health functions results, we have taken out 3. The functions gave a good idea of the capacity that exists in the country and where the country needs to go to strengthen the delivery of services. The next result was the result have been used to support the PAHO country cooperation strategy development and to align the technical assistance to the gaps. And the third one, the renewal of the reform plan that I just talked about of the Ministry of Health, have also used the information to identify the gaps needed to be filled in the reform process, and it's still going on. Looking at the gap analysis and the action plan, the identified gaps were listed in high, major, medium, and low priorities. The priorities were listed high, medium, and low. And under each of the functions, intervention areas were identified and strategies and actions were developed to fill the gaps. Timeline for the implementation from 2023 to 2025 were also identified along with the lead and supporting partners in the process. Suriname is using a multi-stakeholder approach to ensure the intersectoral engagement, and we're working along with other ministries, civil society organizations, NGOs, and private sector. And this is being done through health in all policies initiatives. Looking at the overall recommendations, we have summarized the actions to strengthen the institutional capacities and the MOH, the Minister of Health priorities. 4 areas of the high priorities that came out were the access, the assessment, policy development, and resource allocation. And the areas that are highlighted here in green, these are focus areas of the Ministry of Health Policy Plan 2001-2025, and these will be, those were already in the plan, but will be reinforced during the process. Yeah. Our experience with this evaluation, with this assessment, we found that it was a very complex and long tool with a lot of questions. It required dedicated resources, and it is very time consuming, but it gives a very comprehensive view of the current capacities and also the gaps. And it can be used as a reference document to drive the transformation of the health sector in Suriname. Thank you very much for your attention.
Many thanks, doctora Laquichela. Muchas gracias por su presentación. Creo que da una, primero felicitar porque es el primer país de la región que
Congratulations for this presentation and the strategy for assessing healthcare systems and designing an action plan and identifying gaps and furthering the design of intervention areas on key issues. So the reflection is that this is what allows us to have a strong incentive with regards to public health care functions in the Americas. Next, we are handing the floor to, we're now going to introduce Dr. Andrea Garito Castro. Dr. Garito is Director of the Planning Office for the Ministry of Healthcare Costa Rica. She has a degree in medicine from the Autonomous University of Medical Sciences with a master's in healthcare sciences from the Central American Institution of Public Administration. She has 10 years working with the Ministry of Health and has coordinated many regional efforts in Central America. Welcome, Dr. Garita, and please go ahead. I remind you that we have 10 minutes, so we beg that you stay within time. Yes, of course. Thank you so much, and please confirm if you can hear me and if you can see my presentation. We can hear you properly, but let's see. Still not showing. It's appearing. If you could set it to full screen mode. Yes, just give me a second.
Perfecto. Ahí se ve muy bien.
Yeah, ¿verdad?
Great.
Muchísimas gracias.
Thank you so much.
Bueno, para
Well, for our country and for the Ministry of Healthcare Costa Rica, it is very important and we feel very flattered in having been invited to participate in this such important space where we can share experiences and also see experiences in other countries and on different actions that they are developing which contribute to the health of our peoples and which are really very enriching. Perhaps to begin and very briefly, just to set you in context and to understand a little the process that is being developed in our country. Well, Costa Rica is a small country, just over 5 million inhabitants, where our healthcare indicators are good comparing to other countries in the region, mainly regarding life expectancy, child mortality, and the more. We have healthcare indicators which are really a reason of pride for our country. But we also have many challenges, and I believe the process we have developed on essential functions in public healthcare, well, have made it evident regarding challenges that we must face at this time, and even more so, the challenge increases since we are still in the process at the country level where we are experiencing the consequences of a pandemic as strong as COVID-19 has been, and which has significantly impacted the status in healthcare for our population. Also to understand that with regards to the future of healthcare in Costa Rica, the picture of the ruling of or jurisdiction on healthcare is on the Ministry of Healthcare, where all public institutions are centralized to have an explicit purview with regards to improving and maintaining the healthcare status of the population, but we also have purview in the national system, which incorporates not only public entities, but also private ones, national and international one, which relate among each other and which have within their primordial activity also the provision of goods and services related to tending to the health care of the population, and also making use not only of the legal framework, but other tools in purview such as advocacy, leadership, as we exert that purview on the social provision system of healthcare. So we have a set of social stakeholders interrelated at this intersectorial level, which impact according to their duty in a significant manner on the many determinants, social determinants of healthcare in all of their aspects. We are also based on the concept of public policy that MIDA plan establishes, which is the Planning and Economic Policy Ministry in our country, which sets the guidelines and directives with regards to planning issues nationally, where it defines policy as online course, a line of action defined to attain an end which is expressed in goals, strategic goals, guidelines and actions on an issue or attending to a problem of public interest, which is translated into decisions and is supported in mandates, agreements, or commitments that can be national or international. This is the starting point that is so important to us because it is conceptually on what we are basing our national healthcare policy. Also, among our concepts, we stem from the fact that policies allow to overcome or diminish issues that come up in a determined society, and also very important to mention that with regards to public policies in healthcare, it is the Ministry of Health, the only responsible party with the jurisdiction by law for formulating the national healthcare policy apart from its follow-up and assessment and any other specific policy to healthcare that is to be generated.
Well, we also like to mention that this is contextualized in the cycle of policies that have been developed through four main components. And this is something that we've already mentioned in previous presentations, which are access, evaluation, allocation of resources, the development of policies where we can see the 11 PES. The Ministry of Health of Costa Rica has also used this new focus or approach to look over the policies of public health in the country and all the projects that want or that that we are looking to implement in the future. They need to go through the planning instrument so it can be implemented in the national structure of public health. In regards of the process of the development of the national policy of health, it's also important to mention that this policy and the ingredients or the results that we can get from this policy were obtained thanks to each of the steps that we've taken in the measurement of the essential functions of public health that have been renewed, mainly to mention a couple. Since the first phase, we were able to obtain updated information from the health situation analysis. And this is what's important for us because these analyses of the national health situation that we had when making these policies were from 2019. And this document of situation analysis also and already includes information from 2020, 2021, and even the first few months of 2022. That for us was fundamental, especially because we wanted or we had data that were reflecting our indicators as a product or that had an impact related to the COVID-19 pandemic. And we also had to do a mapping of the main social stakeholders that were important in measurement process, but also in the policy making process for health policies. We had that fundamental point so we can do our own working groups, put them together and work with them at the same time. And in general terms, the result of this measurement and the identification of the gaps that we'll talk about a bit more in a while. How did we incorporate this in the policy making process of the national health policy? We were able to obtain that information, which was really important, and that we were able to work with the social stakeholders, where we achieved not only to identify the gaps, but also to make an analysis and a process of notification of those that had common elements, and also in the stage that we are at right now, which is the making of the plan for the strengthening of the feds, which would be compile of the actions that are defined already for the making of the national health plan, where we wanted to be directly linked it to this national instrument for planning. We have incorporated then in our country our fourth stage of the process or assessment of FS, which is the link that we are able to do, taking the result of the measurement that we've done as a main ingredient for the development of the national health policy, for the national health plan, and for the specific plans and projects that can be developed and the plans that we want to put together in the future, maybe. Also, and beyond the gaps that have been identified in the evaluation of FES, we have as a different ingredient for the evaluation of the national policy for healthy analysis of the national situation health-wise, and also the review of reports nationwide, nationally related to policies, or where we have identified some diagnosis of public health where we consider that there's something to move forward with as a country. We have some critical countries to cover and to face. So we had to do this whole review beyond or on top of the one that we've already done for this specifically. We needed all of these elements to define the critical matters that would be derivating later on onto guidelines of the National Policy of Health. And more specifically, in the process of policy making for the National Policy of Health and in regards of the advances that we have right now, just as I mentioned, from the prioritization of the results of the generated ingredients in the measurement process for essential functions in public health, we were able to identify the gaps from the measurement process that we have, where we have initially identified 300 gaps in a process where we had the participation of over 200 social stakeholders in each one of these stages. And we were able to reach expert groups for specific functions in public health. And in overall, we were able to identify 351 gaps. Afterwards, what we were able to do is with an expert criteria to unify those gaps that had common elements and that could have a common interventions in the future so we can face them in a planification of gaps process where we have or we want to work on 156 gaps that we have identified. Additionally, since and from the follow-up and evaluation unit from the Division of Planning of the Ministry of Health, we've defined a series of criteria that we will look at further on that allow us to use this instrument in Excel and to prioritize these zoned gaps with social stakeholders so we can select those that have or scored higher and that can enable the process for the plan that we were doing for the intervention of the FES and for the national health policy. And this is because we know that as a country, we have a lot of challenges to face. The information that came from this measurement process is enriching, and the discussion that we had with the social actors and stakeholders was also key. But we also need to prioritize because we had elements that were urgent to respond to and that we needed to tackle as a country, and where we saw a more fertile landscape to move forward with the interventions at the short, mid, and long term. I'm sorry to interrupt you, Dr. Garita. We don't have much time. Can we please wrap it up because we are over 10 minutes? Yes, sir, I'm almost done. Thank you. So I was saying that from these new gaps that were selected and that score higher, we were able to do the analysis and to transform gaps that we've identified with social stakeholders and that we immediately transform into policies, guidelines. Or where am I going to align myself with to be able to tackle this critical matter? So you can see our direct connection with the results of the measurement process. Well, I'm not going to deepen into this because of time, but you can see here the criteria of prioritization that we have defined to be able to prioritize the unified gaps and the feasibility, interest, transcendence, and gravity of problem, where we have established also a scale of measurement that go from one that was lowest one, 3, which was moderate, and really high, which was 5. And then again here, due to timing issues, I cannot dip into 2, but we made a tool in Excel that will allow us to work in even virtual way with social stakeholders in a simultaneous manner where we can see each and one of the unified prioritized gaps by FES and allocating or assigning a score by according to the criteria that we have established so we can have prioritized gaps that afterwards became the ingredients for the making of critical matters and the guidelines that we are defining nowadays right now when the national health policy as a country for us has represented a huge challenge from the moment that we thought about doing the essential measurement in public health, we tried to look over a wholesome process articulated from the measurement till the making of the national policy for health, the making of the health plan, and afterward the making not just of the specific health plans, but also internally in our institutions in the making of the strategic institutional plan where we already establish goals within the institution so we can move forward with the compliance of the objectives that have been established in the national health plan that at the same time linked with national health policy. We continue working. It is really enriching and a huge challenge to do that linking and relation, but we hope to move forward according to the objectives and the purpose and the schedule that we've established. Thank you very much.
Muchísimas gracias también, doctora Garita. Muy interesante la presentación que...
Thank you very much, Dr. Garita. Really interesting information that you're sharing. It's an interesting application, just as Suriname, that will be the heart in health planning according to what the country has. But it's been doing really good. And that was really interesting because the process allows us to integrate all this fast in the planning and reaching prioritization goals and solving some of the challenges that we see in front of us. Thank you very much. Now we'll go to Dr. Carlos Alvarena's presentation by the Ministry of Management for Health Management in El Salvador. Dr. Alvaranga is a medic in pediatric surgery with a study and master's in medicine. Has a broad career in the field. He has occupied many positions in the ministry and at the same time has been the president of the Association of the Radic Association of Salvador and has worked in bioethical in the different health institutions. So thank you very much, Doctor. It's a real nice thing to have you here. Welcome. Thank you, Dr. Tapia. Thank you for the invite. This activity that's really important for the majority of health systems in the world. We'll put out the presentation or the slide. You can see it, right? We'll assess the pandemic, and the pandemic has constituted a huge challenge that face health problems in these last few decades as such. So it also generated some tests to the sanitary systems worldwide, leaving aside and uncovering weaknesses and inequalities in countries of low resources, but also in first world countries. This problem created a lot of challenges and important obstacles, but it also has created opportunities because it has changed all the systems, all the social sectors, political, economical, and there's a sensitivity toward the sanitary system that becomes an opportunity. And that's why it's precisely that in El Salvador we have created a vision of change. We are basically taking advantage of the crisis to generate a re-engineering, a full re-engineering, a reform of the sector. And this model that you have here is a model of the system. We always talk about systems and system. What is a system? It's a management tool. It covers input and output, and input would be to improve capacities of the system so we can improve at the same time essential processes, meaning the essential functions of the system and to generate the results and the impact. All of this under one undiagnosed baseline that starts from a diagnose. And we need to do it like that. And in the upper side, upper part where you can see the regulational, international side of it, with the sustainable development goals, primary health service and attention, and different documents that are referenced to it. But in the, as a base of the social determination of health, we can establish a system of health and we would improve it at 20% probably. That's why we need to focus a lot on going outside and having a different vision towards the results that we are looking for. What are we doing in the country? We're implementing this new model, as I said, based in a diagnosis, and that will be focused not just in being curative, but also on our well-being. That's why we've retaken the essential functions of public health that are renewed as a tool of assessment to assess the capacities that we have to provide a response to the essential functions of the system. This model is really important because based on the model and the structure that we're looking at right here is that we've been able to look at as a country the whole process of evaluation. In the evaluation cycle, in the topic of development of policies, allocation of resources, and the access as such, as we've seen in different presentations. This is the assessment process, the general one in El Salvador at least. And we started out in a phase 0, which is the organization side of the evaluation that took like a month. And afterwards, the phase 1, which is the analysis of the situation and an institutional mapping, these took us an extra month. Then we had to make an intermediate to gather information. Then we had a second phase, which was the measurement of institutional capacities. This is the strongest part to assess fast as such. This is what we took around 4 months to do. And one last phase that we just finished on December 3rd was the gap analysis and information analysis that took like 3 months to develop. And from there, we can develop an action plan and a national health plan. This is the perspective. This is the route that ourselves as a country and as a degree want to achieve. And we are one of the few countries that have completed and implemented this evaluation process of FSS renewed as such. In the phase 0 of the organization's development, we have observed a coordinations team from the health system and a creation of an interinstitutional team from all of the institutions related to the health sector. We have 17 institutions and we implemented a training process for the technology that we're going to implement. And we found a way to do the evaluation test of the phase as such. Within this perspective, we worked on phase 1, which was the situational analysis and situational mapping, where we can see that we worked with around 218 institutions that provided information to conduct this first approach of an analysis situation or situation analysis and to do a map out. Out of this, 138 were from the health sector and 80 from different sectors that are outside health. And as well, we conducted analysis of the legal aspects and regulational aspects, and you can see there at the bottom 104 regulations among laws, regulational documents, regulation codes, rules that had to be assessed again. So we can make it part of this diagnosis that we do as a whole. Carrying on with the first phase, this showed us, or at least in institutional mapping situation, we established that some of the key stakeholders were public sector with 70% in response to the whole population, social security that has 26% of the population, and the private sector that has 0.1 of the population, of the whole population. So we've done some analysis with our institutions of the sector and some of them out of the sector that are going to give us aspects such as the demographic attraction and entrepreneur or demographic aging and then the scheme in the rural and urban area and the increase of inequality, the concentration of richness, the aspects of lack of education and in the budget that we are establishing to help alongside in comparing it to GDP that next year can be up to 0.4. We have assessed human resources for 2021 of 13.96 doctors per 10,000 inhabitants. We've measured cultural barriers, vulnerable population, just as for governance, juridical framework, and the rectorship as such. These were the elements that we've assessed and valued in this first stage. In this second stage, which was a stronger phase, was a measurement part of capacities. This phase participated more than 157 people from different institutions of the national health system. And just to develop this phase, we had to go through a course of public policies that are renewed and a virtual platform that we use to make the measurements. We had the participation of many institutions and the First Lady, the academia, and the sector as such. So what did we generate if in this first stage in the evaluation of four different type of capacities to assess? These were the capacities, the formal capacity, which basically were the capacity and regulational part that gives us a structure of rules within an institution that will be providing the support to this whole system, and the capacity of supervision that or accountability systems such as monitoring a report that would aid towards our function in the capacity of performance, which basically have to do with the in areas of competence to develop our position in our own work in the health sector as such. Every one of them is focused through the first use. We also use a leaky scale from 1 to 5, and we saw an initial capacity where less than 20% of the capacities have been established is used, then a limited capacity from 20 to 40, and then a moderate capacity from 40 to 60, an intermediate capacity from 60 to 80% of the standards. And if it was above 80%, it was an advanced capacity as such. And you can see this graphic here where we are assessing each one of the first. Just to show you graphically the bar to your right and the upper side, you can see the description of the leakage scale. And in bars, you can see how much did we obtain. The main gaps that we had, the standard process, the use of information, and some of the aspects that we need to improve, like the law for research in health. And these were the ways that we've been assessing the capacities as such. This is the second part of the cycle, the development of policies too. The same focus. I'm not going to stop here in the results, but we are looking at the methodology that ourselves as a country we develop, and that is a main line or the baseline to improve our strategies and the necessary projects so we can decrease the gaps that we've also identified. In the third cycle, the essential functions of public health that were uh, allocated resources ended up as such. And finally, the first part will be, or the last part will be the access. And those are the three phases related to the access. And we generated analysis of gaps, identified that were the output of this type of second evaluation. Then we made an analysis in our third phase where we made a gap analysis and an action plan where we had around 641 gaps by phase, but in El Salvador we found 348 hours. And we made some unified gaps in a unification of gaps, and we found 244, and we prioritized 64 gaps as such. What did we find in this gap and action plan analysis? 73 objectives that have been or are being implemented, 185 strategies, 70 people responsible, and at the time from 2 to 36 months, and 175 indicators to continue providing follow-up to this new focus. As you can see here, the action plan and the structure of the action plan as we've implemented is again where we see the unified dates, the goals, the strategies responsible, the necessary alliances, the time and resources, the monitoring and implementation of strategies plan, and the type of high priority, high, medium, or low priority of that's something important, and something that we've also considered our roadmap is to comply with the evaluation of the three phases from 2020 to 2024, since the approval of the action plan, its review, till its dissemination, implementation, and afterwards for 2024, for January or April 2024, we can have a meeting of accountability of this action plan and the making of an advance report to take make timely decisions. It's a, like I said, a really hard work, but really well structured as well. That took a long while, and it's a brief type of document gives us baselines to be able to improve in that health structure that we are implementing as such. The summoning is to make a reengineering of the health systems, a reform of health. because precisely the crisis that the pandemic has generated is a huge opportunity, it's a window of opportunity that will soon be closed, especially in the financial aspect is the one that's going to be the most important. But nowadays is the sanitary issue. And nowadays we have to establish establish it towards a new focus of population's well-being. Thank you very much.
Bien, muchísimas gracias, doctor Alvarenga.
Thank you very much, Dr. Alvarenga. It's really interesting presentation. We're always really happy to look at this type of concept of planning impregnated with strategies of public health in batch with development. I can see here that there's a lot of topics here that at the end the whole region, and particularly myself, because I've been in El Salvador and I love working there, and to look at the capacity that's going on there, it's really important. But this is something really timely. I'm just extending a bit because of the love of the country that has almost for an eruption. Okay, now this is your house. Thank you. We'll now go to directly to the closing of our session because of timing. We will incorporate all questions to the strategy of refining of the process itself. We would like to remind you that all the presentations of this webinar are going to be uploaded in the website of the event. And then at the same time, the recordings, we will be sharing them with you in the chat box. Again, the link is there to our webpage. And with any further ado, let me open the mic to Dr. Ernesto Vasculo. That, as our colleague said, Dr. Vasculo, as they mentioned, is Chief of Governance of PAHO and WHO and interim chair of Health and Access of PAHO. Please, Ernesto, if you can join us with a few remarks. Thank you, Roberto. And it really has been a pleasure being witness and listening to all of these experiences, not just of the results, but of the processes that are behind all of these exercise of essential functions of public health, looking after uh, looking after each different context, getting to know the making processes of policies in each situation with your own particularities and characteristics. I believe that it allows us to acknowledge, recognize certain lessons, and it's also a big reason of pride about how the whole region moves around and it's articulating and generating efforts towards this direction, incorporating the essential functions of public health as an important part of the agenda transformation of health systems, which for me, I believe there's some critical points to try and cover and put it up in the table. One of them is the measurement of capacities. Whenever we talk about capacities, it's not only an empty concept or aspirational concept. They could also be measured and it could also be incorporated in transformative agendas of institutions. The second point that I believe is important has to do about how are we going to articulate in each one of these countries and contexts the analysis of capacities with the making processes for policy or the process itself for making policies. So there's a lot that's been said regarding strengthening health systems, the authority of, or the governance of the institutions, and we'll are shown how we are always talking about in terms of objectives of what to do, but countries are showing us how to do it. And I believe that this is one of the key points. Another thing that I would like to highlight from what this seminar was has to do with the articulation of many stakeholders, not just in the implementation process for the tool and the design of the tool, the incorporation of the academic world, incorporating these public health functions to their own curriculum. How the academic space And in the case of Brazil, it interacts and participates of the key process of political dialogue with different states taking away the tools to their own reality, not just the importance of the health authorities, but some of the stakeholders like the public health schools have been critical to rethink about these new essential functions of public health, but the concept itself of how should they be strengthened in the territory. And as previously Dr. Marcos Pinal said, how PAHO is putting themselves at the disposal of the service and to work towards technical cooperation that would strengthen the capacities from countries in function of their own needs, in function of their own processes. And finally, I would like to invite all of you because this same activity it's a part of the celebration of the Universal Health Day. On the 12th, we have a high-level encounter, a seminar, a massive seminar, a really interesting seminar called To Build the World That We Want with a Healthier Future for All of Us, with the participation of Director Carice Etienne and with authorities of health of different countries of the region. Please, I'll ask you to attend because it's a good opportunity to listen, to raise our voice, and to ask not just the need of towards universal health and to ensure the right to health for everyone, but also the needs that we have in the region for everything that we need and how can we move forward in that sense. I don't want to
Un gran agradecimiento a todos los panelistas, sus presentaciones excelentes. Hemos tenido presentaciones en el Caribe, en Centroamérica, en Sudamérica, cada uno con sus
I want to take
características.
We've held
advantage of the opportunity to thank
presentations in the Caribbean, Central America, and South America, each with their own features, which has been incredible, and also to the interpreters, of course. Please, Roberto, in your role as moderator and also an HCS team from the incredible department, Karina Benson, Natania Hoto, but we also have Rachel, Freddie, Andres, Raul, has participated in most of these activities, and even in the past, Juan, Mark now, who has helped us incredibly, and of course, Nestor, Rosana, previously Alejandro. There's a team that is not only technically involved, but in this need to guide technical cooperation, strengthening that perspective from the countries, strengthening that capacity from healthcare authorities, articulating many stakeholders, facilitating those processes. So nothing, gratitude goes out to all. And so not only this seminar is ending and partly the cycle for this year, and partly the continuation of furthering working processes also from last year. And well, we'll be expecting you on Monday in this activity for universal health. And thank you so much to all participants who have been with us throughout these days. Thank you. Thank you so much, everyone.
Gracias, Roberto. Gracias, Ernesto. Gracias a todos.
Thank you, everyone. Thank you so much. Bye-bye.
Muchas gracias a todos. Saludos.
Don Carlos, gracias, Lucy. Que estoy bien. Ya. Muchísimas gracias a todos. Eso. Adiós, Luis. Nos vemos.
Chao, Roberto. Gracias. Nos vemos.